today. My name is Marianne Huff, and I am the President and CEO of the Mental Health Association in Michigan. And if you don't know who we are the state's oldest statewide advocacy organization that is focused on all age groups, 0 to 110, I always say, who have mental health conditions or addictions. So we're really glad to have you here for this webinar today. I think a lot of people are aware that there's been a lot of discussion about integration of physical and behavioral health care for a long time, and especially when the Affordable Care Act was signed into law back in 2010. The state of Michigan continues to debate the subject of integrated care. And that is currently happening in our state again. When you look around at the arena of public mental health, at the same time, we should be talking about healthcare anyway, because particularly in light of the pandemic. But one of the things that we really were looking at as an association, as an organization, is what exactly is integrated care? And why should we even talk about integrated care? So the federal government, namely the Substance Abuse and Mental Health Services Administration, or what we call SAMHSA, has been working collaboratively with the Center for Excellence at the National Council on Mental Wellness on a new model of integrated care. SAMHSA has been working with the National Council at the federal level. Basically, SAMHSA is going to be coming out with a much more specific model of integrated care. It's going to have more specificity around activities that are essential for care to be successfully integrated. We're looking forward to the paper to be completed in April of this year. We're really looking forward to it. One of the things that, we've also been paying a lot of attention to, I think a lot of people are, is there's a lot of suggestion out there about how do you integrate basically mental health and physical health care. And one thing that we've noticed is that the voices of the people who really matter and who will ultimately live with what is chosen for them as a model of both mental and physical health care, their voices are pretty absent in the conversation. In light of that, I also wanted to mention that this evening, our discussion of integrated care is not a political discussion. What we're talking about today is a holistic approach to health care. From our perspective, there is no distinction between caring for the body and the mind. Maybe what we need is a clear definition of what healthcare is, along with what is a clear definition of integrated care. So for us, it's really vital that the voices of those who need behavioral health services are heard. And so we want to make sure that these webinars are not only educational, but that they give participants the opportunity to voice their thoughts about what they think integrated care is and what they understand about it or don't understand about it. One more quick item, it's really not a item I want to talk about, was in the late summer of 2020, the Mental Health Association in Michigan, along with representatives from some other disability rights organizations, as well as a consumer representative and Dr. Panero, who is one of our presenters, we all got together to talk about how do we increase the voices of those who will live with whatever integrated care model is ultimately chosen in our state. At that time, there was nothing going on legislatively with regards to integrated care. And so we wanted to make sure that if that conversation ever came around again, and it certainly has, that the people that have to really live with whatever is designed for them, that they have a voice. And of course, we know too that there was a model put out there by the previous MDHHS director, but then things got sort of co-opted by COVID. The group of us met for about 4 months, and we created a series of principles that we believe should be part of any effort to integrate care for individuals. We're not going to go into that today, but I just want to let you know that there's been some work done around, what should some of the values be around integrated care. All of that being said, I want to welcome you to today's webinar, which is the first in a series of 3 webinars that begins with an open discussion about integration of physical and behavioral health care. What is it? What isn't it? What do you know about it? Why should you know about it? And we have two great experts here. We have Dr. Angela Pinheiro, MD, and we have April Briggs. These are the panelists. April is going to talk about a brief integrated care survey that MHAM conducted in the summer, fall of 2021, just looking for information from folks about what they knew or don't know about integrated care. And then Dr. Panero is going to talk about why we need integrated care in our state. Why should we even be having this discussion? First, I'd like to introduce Dr. Angela Pinheiro, MD. She's a medical doctor and a psychiatrist. She graduated from the Michigan State University Psychiatry Residency Program in 1990 and subsequently obtained her Juris Doctor from the Michigan State University College of Law. She's worked in the community mental health system for over 32 years as a psychiatrist and is currently the medical director of CMH for Central Michigan. She's an active member of the Medical Director Institute at the National Council for Mental Wellbeing and is a certified psychiatric trainer in Michigan's first episode psychosis program. Prior to entering psychiatry, Dr. Panero was in an internal medicine residency program, which gives her a sound platform to understand the need for integrated care. So we want to introduce Dr. Panero. April Briggs is a junior at the University of Michigan Dearborn, majoring in communications with a minor in political science. She is very passionate about mental health and helping people get the help they need and deserve. She was an intern with Mental Health Association in spring of 2021 through the end of the summer, and she focused on a large project surrounding integrated healthcare. She developed a survey to collect the data and opinions from people across the state of Michigan. She also conducted research on successful integrated care healthcare programs, both internationally and in other areas of our country, very knowledgeable about what they're doing in the United Kingdom, particularly in England, around integrated care and ensuring the consumer voice. This research, combined with the data collected, can help us give a better understanding of what the people in Michigan want from integrated care and how we can implement the positives from other integrated care systems. So our presentation is going to begin with April sharing the aggregate results of the integrated care survey that was conducted. And it's also going to be interactive because you will have the opportunity to participate in a poll. So I'm going to go ahead and turn it over to April.
Thank you everyone for being here. I actually did just share a link into the chat. This is a short survey. It's 5 questions, very similar to the survey that we distributed over summer and fall. So if you want to go ahead and click that link, you can fill that out. It just kind of helps spark the conversation about what you know about integrated care, what you don't know, and what you prefer as well. Very similar to what we did in our survey. So as Marianne mentioned, in thinking about integrated care, what it means, how it works, we were mostly concerned with asking the people. Really, that was our basis of our survey. It was important in our survey to be simple in that and to not define integrated care because we wanted to make sure that we weren't giving any information or leading the conversation so we could find out what the people in our state really thought about integrated care, if they knew about it or if they didn't know about it, and if they wanted their care integrated as well. So with that being said, if you guys want to go ahead and take that survey, I'm going to start sharing my screen to share some results that we got from our survey as well. Our integrated care data. So here is what MHAM heard from others. Basically, this is what the average person in Michigan knows about integrated care, what they think about it, and the questions that they had. We were super concerned with finding out engaging what the average Joe or Joanna knows. So similar to the questions that you're going to see in the survey that I just put into the chat, this was one of the first questions we asked. Do you know what integrated care is? Here's how the results came out. So we wanted to know if people knew what integrated care was without defining it again. So 43% said yes, while 29% did not. And 28% have heard about it, but are unsure of what that means. This actually helped to show that 57% of respondents didn't know or were unsure of what integrated care is, kind of pointing to the need to talk to people in our state and really provide education and information about integrated care. The next question, in including access to mental health care, we asked how important that was for people and their families. So 87% of people overall considered access to mental health care important to them and their families. As you can see, it goes over from very important to not important at all. It was also important for us to ask how mental health care stacks up in comparison to physical health care. Is it as important? Is it more important? Or is it less important to the people? Overall, 80% agreed that the two are of equal importance, which was huge, while 17% felt mental health care was actually more important than physical health care. In considering integration at the primary care level, we asked if having your medical doctor ask about your mental health was something that people wanted to happen. And 63% of people said yes, while 24% remarked maybe. We did not go into detail exactly about what this would look like at the primary care level with referrals and integration process or the continuum of care, but this was actually helpful in showing people that the people are actually interested and open to an integrated care system or a collaborative approach with their care. Asking if you want your healthcare integrated, we added a simple note that integration was including the entirety of healthcare combined, which was physical and mental. So do you want your healthcare integrated? 47% said yes, while 13% said no. What was most helpful was seeing that 41% overall wanted more information about what this meant, meaning we have a real opportunity to inform and educate the people on integrated healthcare. To follow that up, a simple question on if you wanted to know more about integrated healthcare was simple. While 18% said no, 82% said yes or maybe. Again, this just reiterated that the people want to know and understand the system of care and what integration means. Finally, we opened up the survey to comments and questions and received some great feedback from the participants, which is what we're asking of you today. We're going to have a series of questions, and please feel free to answer. You can raise your hand in the function, or you can type in the chat or speak up. We have this series of questions and we want to spark a conversation about what integrated care means. So first and foremost, do you already participate in or have experience with integrated care through private insurance, a healthcare provider, primary care, or through the community mental health system? Does anyone want to talk about that, their participation in an integrated system and what that means?
Hi, my name's Celeste Camperwalla. And yeah, so I have a general care practitioner through IHA, and my mental health providers are also through IHA. And I'm really pleased to say that my main healthcare provider, my doctor, asks me, she regularly checks in with me when I go in for a physical to ask how I'm doing mental health wise. A few years ago, she did prescribe me some medication and continued to follow up with me. And I now work with my mental health care provider and my psychiatric nurse practitioner. And the communication it takes place in between all of the doctors and all of the prescribers. So I've had a really good experience, but I know that's not the case for everybody.
Thank you so much for sharing.
Yeah, I can speak to that. This is
Great.
Christine, and my mental health care before, it was combined, but I had to pay out of pocket for pretty much everything. The only thing that they would pay for is half of a psychiatrist visit. They wouldn't pay for any counseling or anything. So once the Affordable Care Act came in with the parity, then, my care became covered as the, mental health was the same as physical health, and my copays are the same. And now I can afford it. So I go more often, whereas before it was always a budgetary concern.
We actually heard a lot of that kind of feedback about budget and cost in our survey as well. So that brings up a great point. All right. So another question that kind of arose was, what would a good integrated care system or visit look like to you as a patient? That was a huge concern and some of the feedback that we received in our survey as well. What would the visit look like from start to finish, or what would the overall program look like? I think that, that was a big question. Just people wanted to know what it would look like. So we were kind of trying to get some information from you to see what a good program would look like and what a good visit would look like to you from start to finish in continuum of care. So the next question, what are some barriers that you see to integrated care? Do you feel like there's an issue with trust in physicians, availability of visits or physicians or locations?
From the Upper Peninsula, and we have we're underserved in primary care and physical and mental health care, but primary care visits take almost 2 months to establish with a with a new physician. So getting mental health care from a primary care setting takes even longer. So the delays that happen are, one of the major frustrations that we see up here. But ideally, we would have where you either have a direct referral from that primary care physician or co-located services. That's the gold standard to me, is those co-location of services.
Yes, absolutely. Great feedback. Thank you for sharing. I think that was a big thing that we received in our feedback from the survey as well, is the co-locations and availability. How do you feel about mental health care being covered at every medical visit? This was kind of a hot button issue when we got our feedback back. So if you were asked in a hospital visit or a special visit or your primary care or the ER about your mental health, how do you feel about that?
So, one person said fine, and another person said, yes, I think it should be.
So I know that a lot of healthcare visits, they do certain surveys that asks you about how you're gauging your mental health care. It would be something kind of beyond that. It would be, an assessment, essentially, more than just filling out a survey.
Yeah, I'll just read some of the other comments that we have. Definitely should be asked every time, and generally good for people to inquire.
I think that there was some feedback in our survey that they weren't 100% comfortable with a physician, a medical doctor that only focuses on physical issues, talking about mental health care. That's where it comes in that, there's a design for the plan. It's not just a medical doctor that only deals with physical ailments, assessing the situation and prescribing medication and doing treatment. It's really that collaboration and that co-location, that kind of thing, where physical and mental health are dealt with in the same area and referrals are happening, and there's a collaboration between the two sides.
Some of the other comments are there should be questions about particularly items like safety in your home, access to guns. And then another comment, my PAs don't have enough information about general health care for me to trust them with my mental health care.
So that was one of the key pieces of feedback that we received as well. Trust is a big thing. So going back to that question we asked second or third, do you feel like you could trust a doctor, or you have trust in, integrated care and, the medical side of things to deal with mental health as well? So it's great to hear that feedback. I think that's really key when we're thinking about developing great plans for our own state and for our own people, and really making it person-centered.
April, another comment is need to have a mental health specialist at the location of your physical health appointment. That docs don't have enough info about mental health either.
All things that we also heard from the survey. So it's great to get those confirmed as well. Again, that really goes into the planning aspect of it, what the visits are going to look like, what the locations are going to look like, and the type of physicians that are going to be there.
One more, April says, cost of healthcare limits practitioners' time with patients. It's hard to be inclusive with so little time.
You can see, are you concerned if there are changes in cost, insurance coverage, et cetera, as well? Not just cost for your, personally, but cost in general. Obviously, there's not as many mental health professionals out there, and we're having issues staffing certain places and issues. So that's a big deal too, with cost and providers as well. So when thinking about integrated care, and if the plans change, do you have any concerns if your insurance coverage would change or your costs would go up personally? I think the biggest thing that we received in our feedback, and keep in mind that this survey was not just digital, there was also paper copies that were distributed across the entire state. So we were able to reach tons of different demographics. But one of the top that was mentioned multiple times was cost. Would this change my insurance plan? What would the insurance plan look like? Do I have to be concerned about my own coverage? Is Medicaid just as good as Medicare, Blue Cross Blue Shield? Do people with better insurances get better coverage when it comes to integrated care? So those were a lot of things that came up in the feedback.
A couple more comments, April. Unfortunately, language is a big barrier to access mental health providers. A concern about any change in coverage would be choice of providers. And then one person said, my coverage is very good for both types of care.
I think that brings up a great point about, does your coverage change the type of providers that you get to see? Because we've seen that so often.
I do want to say one of the key concerns about health insurance is the deductibles. If you purchase insurance through the exchange, then a lot of times, there's large deductibles that people have to meet before they actually have coverage. And those deductibles seem to be a big barrier to mental health and substance abuse treatment.
So how important is it that there be a collaboration between physical and mental health providers working together? And what do you think about physical providers having responsibility of providing mental health care? These were two pretty big ones too that we received feedback from, which I think that there were a few comments before as well about, not trusting a medical doctor, a physician that deals with physical ailments to really handle the entirety of your mental health or behavioral health issues. So that helps us to really see that we need something that, has the professionals working together in the same location where referrals happen, immediately.
My name is Elena Lacey. I have been a mental health provider. Currently, I work for a PIHP in Michigan. And I was saying, I think a barrier is the data exchange between physical health and mental health providers. Certainly, when we try to collaborate, there isn't a lot of opportunity to communicate readily with each other. But I think another essential component is that, as we know, there's a shortage in providers. And, if we can keep advocating for LPCs to be eligible to provide Medicare services, I think that's going to be really, really important also. So I think, it's the collaboration is absolutely essential. We keep running into stumbling blocks in trying to coordinate care and even get people connected to mental health care after an emergency room visit, for instance, because we don't have the same, level of access and data to connect people.
Thank you for sharing. That's a really great point.
This is Pam Casper. I receive services from Oakland Community Health Network provider. I was previously a registered nurse. And I agree with the previous comments. And also, I think it's important to have the integrated care. Some people need the specialty behavioral health services, and that may need to be separate from what you would see embedded in a primary care office. And the collaborative care can be in a lot of different ways. So I think it's important to keep in mind the right care at the right time, the right scope and duration, and that type of thing too.
Actually, a couple more comments, April. One is mental health is a specialty. Not all general practice providers are up to date on the latest medications for mental health. Another one is collaboration between physical and mental health providers is essential. The bulk of mental health care in the U.S. is already provided in primary care settings, but they need help. The collaborative care model goes a long way in addressing those concerns.
And I think that's the point of this, opening this conversation, because people that work in the system or people that deal with the system or person served, that opinion is so important in this conversation and in developing, a great program for integrated care in our state. So we really appreciate that feedback. Absolutely.
And if I may, I just want to make a comment what Pam brought up about kind of like what we call specialty supports. That is a real specialized type of service, but it's healthcare, and those types of supports and services, they need to be made available too. Those are vital, especially for addressing what we would call the social determinants of health. So thank you, Pam, for bringing that up.
So what is the most important thing to you in considering your healthcare being integrated? I know we've talked about locations, we've talked about access, we've talked about cost. Is there anything else that you feel is most important or should be considered the highest importance?
Access, get on the same electronic health record, privacy with regard to subjects of therapy.
That was a big one too that we found in our feedback was privacy.
Compassion, empathy, follow through, whoever's providing the face-to-face service, patient portals, operation and cost.
Nope. Okay. I think that, that brings up some interesting points, empathy for the patient, a good face forward, collaboration, access, privacy. we're covering some things that we also didn't get in feedback from our survey as well. So this kind of conversation is really important. What would you like to hear from us about integrated care? As Marianne mentioned, there's a series of webinars coming up, pretty much integrated care 101, where we're going to go over what it means, why we need it, successful integrated care systems, what that could look like. So from your perspective, what would you like to hear in this conversation or in future webinars about integrated care?
Is it covered under Medicare? What does Medicare provide? Is secondary insurance required? Does integrated care cover pediatrics to geriatrics? And what are some successful models? How frequently do physical and mental health care providers need to communicate for it to count as integration?
Great questions. And that will kind of lead us to what we include in our webinars and all of our information upcoming as well. And questions that came up in our survey as well. Like, what would that look like? What would visits look like? What would costs look like? Do I have to have secondary insurance? What is a successful plan? And we talked about that a lot, Marianne and I, about what deems a plan successful. And in the research that I've done extensively in England, it's really person-centered. So it is judged by the people that are served more than anything else, which is kind of why we're doing these webinars, to see what the person served want. So just to kind of summarize, this is some of the feedback that we received. We had several surveys to comb through. So I kind of just did high-level things, and we talked about this as we went through a lot of our questions. So concerns about cost, location, and providers, privatization of mental health care for profit plans and HMOs won't result in true person-centered care. So we're really kind of, talking about that person-centered approach. Integration should not mean shifting mental health care onto physical healthcare providers. They are not trained in providing that. Another concern that was brought up as well in this webinar. Concerns about privacy and the sharing of medical information across different providers. This was a big one too. Stigmas about mental health in the physical health world. And then concerns about the next steps. If your primary care does screen for mental health and there is an issue, what happens from there? And what does it look like? And then prefer integration happen at person level, not payer level. So that was kind of high level. A lot of the feedback that we received, again, we combed through quite a bit of it. I just want to say I'm going to stop sharing my screen now, and I can finally see comments. Yay. I just want to say thank you so much for allowing us to open this conversation and for you being so free about sharing your thoughts. It definitely helps us in thinking about the future of integrated care and what that looks like for the people in our state. So that ends me, and I really appreciate your time. Thank you.
Thank you, April. And thanks everyone for participating in a really, really good discussion. So now I'm going to turn it over to Dr. Panero, and she is going to talk about why we need integrated care.
Welcome, everyone, and thank you for coming. I've been charged with to talk about why integrated care. Why do we need it? Why is there an urgency behind it? And why there's so many of the national organizations that are kind of pressuring us or asking us to develop integrated care. So organizations such as the National Council on the Physical Health side, the American Medical Association, SAMHSA, and a lot of the regulatory and accrediting agencies are looking for evidence of integrated care. So today our time is limited. We're not going to be talking about the social determinants of health, though they're very, very important. And they actually contribute to about 50% if you include housing and the other socioeconomic factors to your health in general. We're going to be focusing today only on your health care, which includes both your mental and physical health care, as well as healthy behaviors. So that's the other 50%. So I did want to mention that the physical health side or the health systems are very, very active in figuring out how to address the social determinants of health. So this is a webinar from the NCQA and is put on by Kaiser. Not only are they integrating physical and mental health, but they're developing kind of a social health practice, which I think is absolutely fascinating. So everybody feels extremely comfortable relating their social needs as well as their physical and mental health needs. So I want to look at the need for integrated care from two perspectives. The first perspective is from the individuals who have serious mental illness, usually being cared for at CMH. We have known that they die many, many years prior to their peers that are the same age. And we have known that since at least 1969. And this particular paper actually quotes other articles that were published much earlier than 1969, noting that individuals with SMI die 10, 15, 20, 25 years in their cohort. In 2006, Joe Park from the National Council published this paper, and he again looked at what is the mortality rate for individuals with SMI across the United States. And he found some interesting things. Of course, we already know that they die younger. He noted that the rate of mortality had accelerated for unclear reasons. And the very important thing that he noted is that 60% at least of the mortality were due to common treatable medical conditions, which had modifiable risk factors. So 12 years later, 2018, we had another paper published, and we've had lots of papers in between and since that confirm that the mortality rate is still about the same. We haven't made much progress. This paper, though, did something very interesting, and I love the slide. On the outside of the circle, it talks about the various causes of mortality for individuals with SMI. So, for example, 28% die of cardiovascular disease, 17% or 18% die of respiratory disease, 15% or 16% die of cancer, and so forth. So you can go around the circle. You do have behavioral health conditions, which include substance use and suicide as a cause of mortality, but the majority of the mortality are common chronic conditions that we all suffer from. Inside the circle is what we call the standard mortality ratio. So your chance of dying at a given age compared to your peer at the same age. So for cardiovascular disease is 2.2 times, for respiratory is 3.2, and you can go around the circle and note each cause. Very interesting, unknown causes, though it's only 1% of the cause of death for the SMI population, that is 13 times more frequent than the general population. So that may be due because, perhaps autopsies are not done as frequently for the SMI population than the general population. Approximately 2 years ago, the Michigan Health Endowment had a grant to study the mortality in Michigan to see if it was about the same or if we had made any progress. And again, they noted that individuals with SMI die 15, 20, 25 years prior to their same age peers. So Joe Parks mentioned, common chronic conditions, and he also mentioned modifiable risk factors. And here's the risk factors for cardiovascular disease. So you can see if your BMI is greater than 27, you have a higher risk of developing cardiovascular disease. If you smoke, if your triglycerides are high, if you have diabetes, if you have hypertension, these are some of the risk factors. On the right-hand side, you can see that if you have more than one risk factor, your chance or your odds of developing cardiovascular disease are significantly higher. So if you have 5 risk factors, you can see that your risk is pretty high. So modifiable risk factor is not this, starting to smoke so that you could get a bonus from your boss when you attempt to quit again. But the good news is that we can make an impact on those factors, on those risk factors. And this slide to me is fantastic. If you lose 1 kilogram, 2.2 pounds, you may have a 16% reduction in your risk of developing diabetes. So even though you still may have a high BMI, you may not develop the diabetes. So instead of having 2 risk factors, you only have 1. We also have learned that it's extremely important to treat early. So this is data from the RAISE Navigate trial, first episode psychosis. These are young people ages 15 to 30 who have had minimal to no exposure to antipsychotic medications. And you can see that a lot of them already have multiple risk factors. Over 50% have dyslipidemia, 50% were already smoking, and you can, go down the line, and some even had diabetes. The lighter boxes, which you can hardly see, means the percentage that actually were receiving treatment. So first episode psychosis, already having multiple risk factors, have not been exposed to antipsychotics and not being treated. So we talked about the importance of early screening and treating and working on the modifiable risk factors, and talked some about the statistics. Now I'd like to move a little bit to the real world. And I like everybody to speak up. So this is a 45-year-old woman. She has schizophrenia. She's a consumer at the local CMH for a number of years. Her psychotic symptoms are well controlled. She also has diabetes. And when asked about her blood sugars, she relates that they're good. She can't recall her last A1C, but adds it was also good. She denies any non-adherence with medications or her primary care appointments. Her last A1C ordered by you or CMH was about 10 months ago, and it was 7.3. How would you handle her?
Maybe a diabetes group education experience?
In the chat, it says order another A1C. What type of diabetes does she have?
She has type 2.
Her and Alexa to tell her when to take her medications, to remind her, or a pill box that has alarms on it to remind her or to remind her to test her blood sugar.
There's another one that says call her pharmacy to check on compliance.
How about calling her primary care physician? What is her last A1C? When was the last time she was seen? And does he have any other concerns? Does she have any current complications from her diabetes? Can both of you develop a joint treatment plan for her diabetes? Who will do the diabetes education? Will that be helpful or not? Who's gonna monitor her ability to get her medications, start that collaboration? The other important thing is, even though her psychosis is well controlled, does she have depression? And she's a little vague about this blood sugar stuff and really need to ask more. So the importance about asking about depression is that you have a 36% increased risk in developing eye complications. So has she seen her ophthalmologist? And you have a 25% increased risk of having a heart attack or stroke, even when the controlled for, how well controlled the diabetes is and all the self-care that somebody with diabetes needs to do. If you have depression, you still have a higher risk of complications. So that assessment needs to be done. So the World Health Organization recommended development of protocols. So these are like pathways, joint pathways that are developed between physical health and mental health for individuals with SMI that focus on the 4 things that they mentioned there, from prevention to treatment. It's very important that these are jointly developed with role clarification and that they be uniform across the health system and across the state, because we're looking for evidence-based practices. Joe Parks in 2006 mentioned the importance of integrated care, number 1, and that the care has to be well coordinated, which is part of integrated care, and the need of having quality evidence-based, both physical as well as mental health approaches. SAMHSA has been talking about integrated care for a very long time. They started with the 4 quadrants, and then they had the levels of integrated healthcare, which was actually adopted from a paper in 1995. But more recently, like Marianne mentioned, they're changing from the levels of integrated healthcare, which really emphasize kind of co-location. They have moved from that to framework that has very specific domains and what you need to do in each domain to really advance integrated care. We'll be talking a lot about that in the next webinar. Okay, so that's the side from the SMI population they're seen at CMH. I think it was about 3 years ago. I had a survey, 99.9% of respondents said they want to live longer. So they want their physical health to improve and they don't want to die earlier. So let's talk about from the perspective of the patients who are going to primary care who have depression and anxiety. Okay, so this is another case, 57-year-old male seen in follow-up for a heart attack. The heart attack occurred 2 months ago. When asked about depression, he says, nope, I'm not sad. I don't feel sad. I don't cry. I don't feel hopeless. When pressed, he said, well, maybe I'm a little bit more irritable and short with the family. He also admitted to some difficulty concentration at work. He has no prior history of mood or anxiety. What would you do with him? Men usually don't endorse feeling depressed. They often endorse feeling angry or irritable. So this gentleman needs a very in-depth evaluation for his to see if he has depressive symptoms. And the reason is, even though 1 in 5 meet criteria for depression during the hospitalization when they have a heart attack, the mortality is really highest for those who start experiencing depression 2 months after their heart attack. So you really need that close monitoring for mental health, even without a prior history. This is from the Milliman report in 2008. You can see that many chronic conditions are accompanied by depression. So the treated are individuals or percentages that have been identified and they're receiving treatment. Expected is what the research has shown the incidence is of depression. So you can see that in all of them, there's a lot more suspected or a lot more individuals with depression who are not treated and haven't been identified. So I could go through all of them, but we don't have time. However, the depression, just like with heart disease, impacts mortality. I picked out 2 very interesting, which I wouldn't expect, impacts mortality, but with melanoma, 6 months out, if you have had a structured psychiatric intervention, which was a group intervention, but they screened for depression, you can see that the mortality at 6 years is half as much for the individuals that received the intervention compared to the individuals that didn't. That's significant. Breast cancer. The blue line is if your depression screen or scale is low, showing that you have very little depression. The yellow line shows that you have depression. Your chance of survival is much less if you have depression. And again, this is controlled for the spread of the disease and pain and all the other factors that might confound it. This just shows that if you have depression or anxiety, or if you have both, you actually have a chance of having many more chronic conditions than if you don't have anxiety or depression. So it kind of works the other way as well. On the right-hand side is a scale for disability. So again, if you have anxiety and depression, you endorse many more of the questions as positive. There's been tons of articles, and you can see how the rate of publications is drastically increasing. We did not talk about cost at all, but the top slide is the cost. And the bottom is the outcomes, showing if you treat mental health conditions, even very mild or moderate, that you actually have better outcomes. From the perspective of the population that have SMI or the population that are being treated just in primary care, are they same or are they different? And I would say that they're the same. Mental health symptoms, whether mild, moderate, or severe, have to be identified. and have to be treated because they affect physical health outcomes. And that means a real partnership between behavioral health and physical health. And that's when you're going to come up with ideas on how to address the individual person's issues. There's a paper that's, if it's not on the SAMHSA's website, it will be soon, on advancing integrated behavioral health into primary care. It uses the exact same framework that SAMHSA is recommending for behavioral health integration. The vision is that there's one kind of model for health integration, whether you're in the physical health side or in the behavioral health side. 19-year-old woman with anorexia. This is her 5th medical hospitalization for a low BMI and electrolyte abnormality. Her hospital states that she's, in quotes, ready to discharge. Her electrolytes are fine. She's gained some weight, and her insurance carrier agrees. Okay, she does not currently meet criteria for psychiatric hospitalization. In the past, she has always rapidly decompensated after discharge. And then she goes back to the medical unit because she's too sick to go to the psychiatric unit. And she does not have coverage for long-term placement. Because of the time, I will just answer or give my thoughts on this. One important question to consider is who else might have kind of skin in the game. So we have the physical health provider saying she's ready to be discharged. The mental health provider has real concerns. Who else can we involve? And with this particular case, it was actually the payer who got involved, asked for another week or 2 in the medical unit, which the payer agreed to cover because they were paying so much for her multiple medical hospitalization. And during that time, the behavioral health specialists were able to see her in the hospital, form a relationship. Her rate of hospitalization dramatically decreased. So you really have a 3-legged stool. You have a behavioral health provider, physical health provider, and you do have a payer. And you need all 3 in very close collaboration and relationship to support the consumer or the patient. The payer can have some flexibility and coverage for challenging cases like we just talked about. They also have a ton of data, so they can engage in population health in partnership with the health systems. They can design special programs and new coverage services for complex health or physical conditions. They do have care management, so they can bring a lot to the table. So in the last couple of minutes, I just wanted to mention 2 more things that I think are extremely important as we talk about changing healthy behaviors, because we have these risk factors and healthy behaviors, and we think if we can just teach the people healthy behaviors, the risk factors will go away. But there's this concept of workload capacity and balance. Each of us have innate amount of capacity to deal with whatever we need to deal with in our lives. As they enter the physical health system or the behavioral health system, not only do they have a chronic condition or a condition that increases that workload, they also now have demands that we place on them. You know, you have to take medication so many times. You have to make these appointments on time. You have to do this. You have to do that. You know, why can't you quit smoking? That we actually can traumatize our patients or persons served, and that paralyzes them. And if they experience that often enough, that condition can actually become permanent. And they're seen as non-adherent or premeditative when it's actually a workload capacity imbalance. Like that young person or young man carrying that heavy rock up a hill. If that hill is too steep or that rock is too heavy, he's going to suffer an injury. And then the other thing that really interferes, especially with the SMI population, is the concept of self-stigma. And they feel like they don't deserve care, or they are not used to caring for themselves because of the stigma that they experience. And it takes a long time to get individuals to really talk about how they feel about themselves in a very sincere way so that you can have change. So this is a teaser for the next webinar. This was written by Dr. Jeffrey Brenner. He's a very, very well-known family practitioner. It's not as simple as just navigating and coordinating. It's not as simple as helping the the patient or the person served navigate the health system and coordinating with the primary care. It's much more complex than that.
I have read that Michigan has the third worst lack of workforce in behavioral health. Is there a reason for that?
That's a very, very important question, and I don't know enough to answer it. Part of it may be salary. The pandemic has also moved a lot of staff from CMH to working for telehealth companies or working independently in a telehealth manner. So we did lose some staff because of that. The department has a task force looking at that to hopefully address it.
I just want to thank you all for joining us. And I really want to thank April and Dr. Panero for their presentations and really appreciated your feedback this evening. Our goal at MHAM is to have an ongoing conversation about this issue. Because we know that it's one that needs to be had. It's a very important conversation. Our goal is to provide ongoing education about integrated care. And also we want to continue to hear back from you because the feedback is what's really, really important here. We are going to have another one on May 4th that's going to be informed by the feedback that you gave us this evening and by feedback that we get on the one on April 6th. And any other thoughts that you might have about what you would like to know and how we can provide that education to you. One thing that I'm passionate about, and I think it's because I'm a social worker by trade, is that a lot of times important information like this doesn't make it down to the people that actually need to understand it and have it. So it's great for, administrators and policymakers and legislators to have some grasp of this. But what's really even more important is that people like yourselves who are going to be the end user of whatever is designed, that you understand it so you can make informed choices about what you think will or will not work for you. I think that ends our session for this evening. And again, thank you for joining us.